All right. Good morning, everyone, and good afternoon and good evening, depending on where you are. And welcome to UCSF Center for Global Nursing's Global Nursing Impact Series. This series aims to provide a platform for our nurses and global partners to share their remarkable work, offer valuable insights, and inspire our global community. Following today's presentation, there will be a short Q&A, so feel free to write your questions throughout the presentation in the Q&A box on the Zoom below. I'm Rebecca Silvers, the director of UCSF Center for Global Nursing, and it is my very big pleasure to introduce this month's speaker, Josephine Nabulime. Excuse me, Nabulime.
Nabulime, I know.
Josephine.
Just call me Josephine. I know it's hard to pronounce.
My dearest, Josephine's an emergency and critical care nurse at Mulago National Referral Hospital in Kampala, Uganda. With over 2 decades of experience, she has extensive expertise in critical care, nursing leadership, and education. She is passionate about emergency medicine and leads the team of over 30 nurses at the hospital's A&E Accident and Emergency Unit. In addition to her clinical role, she works part-time with the World Alliance for Lung and Intensive Care Medicine, an organization dedicated to improving the quality of care provided by healthcare workers across Uganda. Most recently, Josephine joined Uganda's National Monkeypox Task Force, established by the Ministry of Health with the support of the World Health Organization, and has been central has played a key role in the case management and containment efforts of monkeypox in Uganda, helping set up mobile health centers and training local healthcare workers to ensure their works and sustainability. Today, Josephine will share her insights and the critical role nurses have played in Uganda's monkeypox response. Please join me in giving a warm welcome to our friend Josephine.
Thank you, Rebecca, for that beautiful introduction. Good morning, good afternoon, and good evening, everyone. Happy to share with you my experience during an Mpox outbreak in Uganda, where I come from. Yes, my name is Josephine Nabulime, and I'm a nurse in
Josephine? I think she's reported some difficult internet this evening, so we'll give her just a second to rejoin.
Let me use my phone. I got disconnected. I don't know why.
Okay.
Um, uh, as I was telling you, the capital city of Uganda is Kampala, and we have a population of over 48 million. And the most unique thing about Uganda is that we have over 50 languages spoken. So you can just imagine what the hell we go through in trying to make our clients satisfied. So next slide, please. African CDC and WHO declared Mpox as a public health emergency of continental and international concern after a surveillance team that was on ground detected a cluster of cases in the fishing community. that was in the central part of Uganda. Ministry of Health activated a national emergency medical team to operationalize a field hospital with effect from 1st of November 2024. And this team comprised of 9 members from the National Emergency Medical Team. Out of the 9 members, 5 were had a nursing background. There was 1 doctor. We had a logistician, the driver, and yes, I think those are the ones, and the IPC in charge. Next slide, please. So this is the team. And the most unique thing about this team was that at least each person had an extra role. We were 5 nurses, but each nurse had an extra role. I'm a critical care nurse with a midwifery background, but I was the nutritionist at that time. The 2 of the nurses that were on the team had qualifications in progress. Had qualifications in IPC, and they took lead in infection prevention and control. Then one of the nurses had qualifications in logistics, and he paired up with a logistician. So at least each one of us had an extra role. Next slide, please. Before we proceed, who are the emergency medical team? What is that? The emergency medical team in Uganda? Emergency medical team is a group of health professionals, including doctors, nurses, paramedics, and other workers who treat patients affected by an emergency or a disaster. These are people that are picked from government and non-government organizations, military, and humanitarian networks like the Uganda Red Cross. And we operate under minimum standards agreed upon by the EMT community and its partners. It's a fully trained and self-sufficient team. Next slide, please. Our response started with a brief from the WHO leaders and the local leaders in the area where I'm sorry, I think it's the internet that keeps going off. So in that picture, we were trying to draw sketches of how we wanted the facility to look like. Next slide, please. So the groundbreaking moments were the first unit that we assembled was a tent that was going to act as a store, because we had 3 trucks to offload. So we had to remember that we get a store where we're going to keep the items that we had moved with. So that was the moment when we were doing it with the local people. Of course, there was a lot of work. So we had to ask some of the local people from the community to help us. Next slide, please. Not only did the team assemble units, but we also had to assemble the items that we were supposed to use, the equipment, like the beds, the trolleys, the monitoring equipment, because remember we are self-sufficient. And the picture on the right side shows how we are trying to fix the flaps on the tent, because we wanted our patients to stay in a safe environment. So we had to make sure that all the flaps were well fixed. Next slide, please. So among the roles that we had as nurses in the treatment unit was organizing and carrying out screening of the patients, as well as patient triage. This was very important because in the beginning, when we reported to the health center where the health center that was attached to the facility, they were doing things they told us for them they were managing some dermatitis or dermatology condition. So we had to do proper screening of these patients, because some people couldn't tell the difference between mpox lesions and the ordinary dermatological issues. So we had to do thorough screening, and the patients that were critical or had conditions that were not fit to be worked on from that health center were sent to a health center for, meaning we had to run 2 units, 2 centers at a time. Another role that we were doing as nurses was patient admission. We could admit these patients, and then the doctors would come to clerk these patients. Then we'll do daily patient assessment and interventions. This was a health center 3 facility, and anybody who was confirmed mpox positive, or any patient who had a condition that wouldn't be managed from the health center 3 would be transferred to a health center 4. So patient assessment was a key role. We also managed and trained nursing staff that we found on the ground. We advocated for resources to improve patient care. Maybe what I didn't tell you, this was a condition that was last seen in the 1960s, when almost all of us were not born. And it's like it was a new condition to many of us. Apart from what we were reading from books, we had not seen an actual patient who had mpox. So during assessments, we could realize that during assessments and management, we could realize that some drugs worked so well on these lesions, and we could advocate for more resources from Ministry of Health. Another role was building and overseeing schedules. This was a key requirement because we wanted to leave a self-sustaining team on ground. Our team had gone to support, and at a certain point we had to leave this team behind. So we had to train them thoroughly well, to build and oversee our schedules. We also had other interventions which I couldn't put down. Like, these patients could be managed individually. Each patient had unique presentation, and this is how we used to manage them. Next slide, please. Patient safety and communication was very crucial to avoid getting infected throughout the response. We maintained the red and green zones with minimal interactions. In that picture, you can see where I was standing was the green zone, which is a little safe. And then the zone across where you see the tents was the red zone. And I was trying to pass on two kits to the person who was in the red zone to pick. The only way we could communicate was through that area. That is kind of a table where we used to slide. Like if somebody wanting something in the red zone, you would just slide it on that table so that he can pick it. We couldn't go in with phones, and the only communication was through that area. Next slide, please. Of course, just like any other response, there are lots of challenges, some of which were inadequate resources to support two sites. We were running a health center 3 and a health center 4. And in the morning, we would begin with the health center 4, do a ward round, and then proceed to the health center 3, where we had put our structure, our facility. So the resources we had were not enough to support two sites. We also had shortage of nurses to cover all shifts. We were only 5 nurses plus 1 doctor, and we couldn't run 2 sites. What we had to do was to work hand in hand with people we found on ground, would cover day duties mostly, and then hand over to the local nurses to work the night shifts. We also had resistance among healthcare providers towards deployment in the isolation facility. As I told you, this was a new disease that everybody was fearing. People were like, we don't want to take chances. So there was a lot of resistance amongst healthcare workers. And I was sharing with Rebecca that apparently we are having 2 outbreaks. That is Ebola and Mpox. And there's a lot of overstretching for the medical workers and resources are there. Next slide, please. Some of the achievements that we had during the outbreak were able to strengthen the nurses' capacity for effective nursing care throughout the response. We also enhanced distress response capabilities in the case management pillar. We used to hold trainings, and these trainings were not only for the health center 3 and health center 4, but for the whole district. We also strengthened local efforts by supporting healthcare team through regular meetings and quality improvement meetings and coordination amongst stakeholders. The meetings that we used to have were not only for health workers, but even stakeholders. Because the moment we left, the district administration had to take over the response. Next slide, please. What are the nursing? What impact did we bring as nurses during the disease outbreak or other disease outbreaks? Leadership is one of the things that we really emphasize. The nurses took lead in IPC activities. And this was not only during outbreak, but even in our day-to-day work. It is nurses who take lead in infection prevention and control activities. For example, in my hospital, we have an infection prevention and control focal person on each unit, and that person is usually a nurse. So I must say we are the people who take lead in IPC activities. Also, we provide high quality clinical care. Nurses organize and man screening points at all entry points and always demonstrate a high index of suspicion at triage areas. During this outbreak, it is nurses who manned all these patient entry points. And then adaptability, we were so flexible. Not only during the outbreak, but nurses are known to be flexible people. We are always willing to take on extra roles in order to enhance patient care. And as I told you, during that outbreak, each one of us had an extra role and we were flexible with it. And then lastly, we were able to transfer knowledge to the local nurses, ensuring sustainability of the response efforts and reversing stigma around Mpox. This is what I've just told you. People were fearing Mpox, and we had to show them that you can really work on a patient and you don't get infected as long as you practice your IPC. So by the time we left, the team had picked up and they had to take over the case management pillar. Next slide, please. In summary, EMT nurses are capable of positively impact the clinical quality of care in an outbreak or during a response, thus enhancing coordination and improve health outcomes for the population served. There's need for increasing capacity during a surge in outbreaks, and EMT nurses have a role in re-establishing or maintaining essential health services. Next slide, please. Oh, this is the question and answer. So back to you, Rebecca.
Josephine, thank you so much for sharing your work. I know Josephine is on our advisory council, and we had regular communication, and then all of a sudden Josephine was gone because she was serving on this response, and it's really incredible to see the work that you've done and your colleagues, and the way that nurses have really been able to lead, serve, and create change in their community, helping manage this. I don't see any questions in the Q&A just yet. So one of my questions that I'd love to hear your thoughts on is, you've mentioned that we have the Ebola outbreak and the monkeypox outbreak. Is there a way to streamline those teams and get them to work maybe together to kind of utilize resources and IPC in the same way? I don't know. I don't know what your thoughts are on if there's a way to kind of organize that in a different way.
Thank you, Rebecca, for that question. Maybe what I didn't tell you, this team is a very big team. The National EMT team is a big team. It has over 130 professionals. And when there's an outbreak, they can pick people who are free, or they can pick upon you depending on your qualifications, because we have different professionals. And like for Mpox, there's a team that is already handling Mpox.
Oh.
Ebola is the team that is already handling. I went for that response for, I think it was 2 months, and then I came back. Immediately I came back, they took me for an Ebola response because I was available. But there's a team that is maintaining the Mpox response. And these days we encourage each district to handle its burden. Let me call it a burden. When we left that district, we left the district administration to handle the Mpox in that region, because even in Kampala there's Mpox. So the teams had to go to other areas, but Like each district has to handle its healthcare needs. I don't know if I've answered you.
Yeah, it's really interesting to hear how the emergency medical teams are organized and the size of your emergency medical team. If I was a nurse in Uganda and I was working, how is it like how do you become part of this EMT? Is there training or is it because you've been a nurse for so many years? How do nurses join this team and what is that? How do they do? Are they chosen?
Yeah. Thank you, Rebecca. Um, Let me say this is I wouldn't say I applied, but the organizers had to look for people with potential. We are not so many critical care nurses in Uganda because it's a course that is less than 10 years old. We are very few critical care nurses, and being that I work in a national referral hospital, I was picked on.
Mm,
From my hospital, there are three critical care nurses who are in that team. And somehow, I don't know, I don't know how other people joined, but it's like they are people who are known to be good at such
mhm.
responses. So that's how they managed to formulate that team. However, there are people who want to train, and we get continuous trainings. I think they apply,
Amazing.
but the initial group, they had to contact us.
Yeah, I was part of the US based response when after the earthquake in Haiti, and you put your name in if you were interested to go, and then they chose who was the most experienced, etc. But then you're on a list, and then they can reach out, and they've reached out again after that. And it's interesting how different countries manage their emergency response
Yeah,
teams.
okay. We also, Rebecca, we also have that arrangement in
Ah,
like for training, that is how we did it. But like we have a database.
mm,
If you are available, they can say call for people who are available for
hmm.
an outbreak, and they ask us to fill in our names. So when you are available, you can register your name, and then
Yeah, that's
if you
really
are depending on your qualifications.
amazing. And
Sorry.
we have one last question from Mary Joy, who's in Kenya, and she said, "Have you been able to control the outbreak? We received some vaccinations in Kenya. Did you get some for your country, and how has the experience been in the uptake of the vaccine?"
Thank you for that question. I think the control apparent we have is by removing people from the community, people who are sick from the community. And for sure, in Nakasongola, where we had that where we went for that response, the method worked. They now have very few patients who really they can manage. But in Kampala, being that Kampala is a very wide and with so many people, the population is so high, the number of patients are still high.
And then
But at least in the rural areas, is controlled.
have you had the vaccine, and have people been willing to take the vaccine? Has their uptake been positive?
Yeah, we got a vaccine which was there are very few doses which they were like they considered healthcare workers. It hasn't really been in the community. It was for people who are really caring for these patients.
Okay, people, oh, so not for the community, but you haven't had enough for them, but you've been
Not
for
the
the healthcare
community.
workers respond in the response.
Yeah.
Yeah, very interesting. Well, thank you so much, Josephine, for joining us for the Global Nursing Impact Series this morning and sharing your insights. It's truly remarkable to hear about your work and your team's work and all the impact that nurses are making in this monkeypox response. So, thank you so much for joining. And to all of our attendees, thank you for joining us today. And we look forward to another engaging presentation next month. Thank you so much.